Thank you. I'd like to thank the association for allowing me to speak here today. I have no pertinent financial disclosures. I am a plastic surgeon. I'm also a breast surgical oncologist, so I do both the resection and the reconstruction for breast cancer. So what is cost utility research? When assessing different surgical approaches, cost utility research asks if the added cost of this different surgical approach, and we'll call that delta C, is worth the added clinical benefit, and that we'll call that delta Q. It addresses the question, when is a surgical approach cost effective over the status quo? And we know that there are two possible treatment options amongst many in breast cancer surgery and reconstruction for unilateral breast cancer in the large-breasted patient. One, for example, is mastectomy with free flap reconstruction, and the other would be volume displacement oncoplastic surgery, and we'll define that in this talk as a large lumpectomy, an ipsilateral oncoplastic reduction or mastopexy volume displacement design, and a contralateral breast symmetry reduction or mastopexy. Now, compared to oncoplastic surgery, mastectomy and free flap reconstruction has advantages. One advantage would be with the mastectomy, presumptive negative margins and no adjuvant breast radiation in many cases. The disadvantages would be more surgery, including the donor site, more complications with major flap loss and mastectomy skin loss, and minor complications including seroma and hematoma. Large volume displacement oncoplastic surgery compared to mastectomies has also its advantages. It's a shorter surgery, has less postoperative complications, and some would argue has better cosmesis with the benefits of the reduction or mastopexy design. It has its disadvantages, the need for radiation to the affected breast, and increased costs because of this radiation, and also a slightly higher positive margin rate. Now, just to bring everyone up to par as far as large volume oncoplastic surgery, this is a patient who had an upper outer quadrant large invasive ductal carcinoma. We took a very large segment of her upper outer quadrant out. Just for reference, her head is coming out of the left side of the screen, and we performed an extended supramedullary pedicle design described by Dr. Loskin, actually from Emory, where we take the infrared pole of the tissue based off the internal mammary perforators, attached the supramedullary pedicle, and rotated it into the upper outer quadrant design, and subsequently bring the Weiss pattern incisions together. And you can see at the 3-month post-op follow-up, she's after radiation cancer-free and aesthetically quite appropriate, but most importantly, cancer-free. The research goal of this study was to perform a cost utility analysis to look at the potential clinical benefits of either mastectomy with free flap reconstruction or large volume displacement oncoplastic surgery, to weigh their costs and subsequently see which one is more cost effective when treating breast cancer in the large breasted patient. Now, there are several steps in cost utility methodology. The first step is the literature review, where we look at major meta-analyses, specifically at oncoplastic surgery, and looking at the clinical outcomes and their probabilities, and really doing the same for mastectomy and free flap reconstruction. The second step is obtaining the utility surveys, and this is the process of surveying experts who subjectively quantify a health state or a complication, placing a numerical score in the quote-unquote badness of a complication, and this is a form of qualitative research. Step 3 converts these scores into quality-adjusted life years, and this serves as a surrogate for the clinical component of our analysis, which is delta Q, as mentioned before. The next step is assessing costs, and we assess costs to each outcome. This is based on CPT and DRGs off of medical national payment data, and this is the cost component of the delta C of our study. Step 5 is really formulating a decision tree analysis, and to those who are unfamiliar with decision tree, really at the left side is the real startup, which is the major branch, which is breast cancer, and this splits into the upper and lower branches, which are the two treatment choices, the mastectomy and the oncoplastic options. And to the right of the tree, we have the final branches, each of which has a clinical component, the effectiveness, the cost, and the probabilities. And as we put all the numerics into the computer model, the tree is rolled back, and that gives us an assessment of which treatment arm is the most cost effective. So what are our results? Well, we found that successful oncoplastic surgery had a higher utility score after surveys were performed with the surgeons with a higher score of 92.6 compared to mastectomy, which had a utility score of 85.01. In this case, higher is better. The utility scores, as mentioned before, were converted into Q quotients, which are the clinical effectiveness parameters. And for oncoplastic surgery, it was higher at 33.16 than the mastectomies of 30.47. So that gave us a delta Q of 2.7, suggesting that which clinically favored large volume oncoplastic surgery compared to mastectomies. How about costs? Well, with cost outcomes, oncoplastic surgery cost more, largely due to the whole breast radiation, on average approximately by $10,000. So which treatment option is more cost effective? We know that oncoplastic surgery was more clinically effective based on our study. with a 2.7 delta with the Q value. But we did know that mastectomy free flap collection was cheaper by approximately $10,000. So the incremental cost utility ratio, which in essence is the quotient of delta C by delta Q, was $3,600 per quality adjusted life year. And this would make oncoplastic surgery cost effective based on the absolute value of less than $50,000, which is the topmost amount that a treatment option has to be less than in order to be perceived as cost effective. In order to assess the robustness of our data, we looked at all our variables and understood that there would be variation in clinical practice in addition to what's reported to the literature. And so we found that of all the variables studied in our decision tree analysis, the clinical effectiveness parameters and variables had the biggest impact in our results. And this can be seen by the tornado plot here. So we took the clinical effectiveness variables and we did a one-way sensitivity and threshold analysis and tested by standard variation parameters if these variables would flip at some point and change our conclusion. We found that if oncoplastic surgery had a utility score of less than 83.6 versus what we had per our surveys of 92.6, it would become cost ineffective. Just to put this into perspective, it's highly unlikely that oncoplastic surgery would ever be that low. We also performed a Monte-Carlo analysis where we variated multiple variables at once, and we put simulated patients through our computer model, approximately 1,000 patients. And even while assuming standard variation on multiple variables at once, we found that 80% of the time, large volume oncoplastic surgery was still cost effective, adding to the robustness of our conclusion. There are limitations to our study. One of the major limitations in this study, there was a reliance on data from the literature review, and this can differ from individual practice. So treatment options should be discussed with the patient on a patient-by-patient basis. So our conclusion was oncoplastic surgery for breast cancer in large-breasted patients is cost-effective compared to mastectomy with free flap reconstruction. It may be subsequently considered as yet another first-line treatment option for the breast cancer patient. Thank you.
My name is Ernie Chu, NYU Medical Center, no disclosures. I want to congratulate you and your colleagues on a very interesting work examining the cost utility comparing volume displacement for oncoplastic surgery versus free flap reconstruction for breast cancer. Your presentation is timely and important as we are in a major health crisis in American history. Cost containment is front and center. This has been an underlying theme at this meeting. As plastic surgeons, we should actively lead clinical studies in this area, which you are doing so well. We can and we must do much better. So my comments are the following. Plastic surgery is elegant, in that there are many ways to solve problems. However, as a practicing academic clinician and teacher, I pause to consider cost as the major first thing to think about. This can be a slippery slope. At the end of the day, we must be able to sleep and we must do what's best for our patients. So may I ask two questions? The question number one is, can you please expand on your cost utility surveys that were done for a lot of us who aren't so savvy on this QC and Q studies? And then is there another way to correlate long-term clinical outcomes in patient satisfaction to cost utility?
Thank you, Dr. Chu. Those are excellent questions. With regards to how we performed our utility scores, I think that's central to the conclusion because cost utility analysis weighs clinical outcomes much more than it does cost. So it really looks at clinical outcomes and looks at cost as a secondary parameter in that sense. The way we did our utility score measurement was using visual analog scales. We did a one-on-one interview with breast surgeons and plastic surgeons to get a balanced review of outcomes for each parameter, for each option. The visual analog scales are based on feeling thermometers. If you think of 0 being death, 100 being perfect life without ever illness, quadriplegia being something like 10, blindness being 20, obviously higher scores are better. And so we sat down, put up scenarios for breast cancer and the subsequent treatment options and potential complications, and asked surgeons, both breast and plastic surgeons who are familiar with both these procedures, what they would score each outcome as. Now, you have variation how to do utility scores. You can use a time trade-off model or a standard gamble model. Each type of questionnaire has its strengths and benefits, but a visual analog scale is well established. The second question that you had was patient satisfaction scores. I think that would only add to the strength of this study. I think in the future, especially through Sloan Kettering, Dr. Pusick's BreastQ questionnaires, looking at patient satisfaction, not only the way how surgeons perceive it, but how patients perceive it, would only add to this benefit. Now, large volume oncoplastic surgery is essentially you doing a reduction but taking out the cancer as well. So we have patient satisfaction on reductions, which have very high scores, as we do with free flaps and mastectomy reconstructions. I could only imagine that patient satisfaction scores would be higher if, after doing a reduction, the patient has no cancer. So you could argue, without, I mean, I think the study should be done, but you could argue hypothetically that the scores would be even higher.
Congratulations.
Thank you.
Andrew Chen from Connecticut, no disclosures. I was just wondering, in your models, did you take into account the difference that with the mastectomy and free flap reconstruction, you have no breast tissue remaining, presumably a lower risk of recurrent cancer, versus the oncoplastic surgery where you still got the breast tissue and the potential costs involved in terms of treating that in the future, should it come back?
That's a great question. In breast conservation surgery, it's well known that while survival is the same after radiation, there is a slightly higher absolute value, about 5% for breast conservation surgery, local regional recurrence. However, those studies don't take into consideration large volume displacement oncoplastic surgery, which takes up approximately 20 to 50% of the breast, so you have really wide negative margins. There was a study recently done in the Annals of Surgical Oncology in 2016 that addressed that very question. Is there a higher local regional recurrence with oncoplastic surgery versus mastectomy? The answer was no. There was a 10-year follow-up by an Italian group that looked at a large number of patients and found no difference in local regional recurrence, specifically looking at oncoplastic patients to mastectomy patients, simply because you took out so much of the breast, plus you had radiation. So that really, we didn't have to look at that for that reason.
Randy Houck from Hershey. Thanks for your presentation. My question regards your utility analysis. I think I caught you saying you had physicians and surgeons doing that. You think you'd have had a different result if you had patients, and particularly if you had female patients doing that utility, because most of the surgeons are probably men.
Actually, in our survey with the plastic surgeons, a majority of them were women. And in the breast surgeons, also, there were a majority of them were women. I think patients would have similar perceptions of their breast, and it's presumptive of me as a male surgeon to say that. But if you look at the BreastQ measurements on reconstruction from patient perspectives on reductions, which are essentially large volume displacement oncoplastic surgery, except you take the cancer out. And then you look at BreastQ assessments on mastectomies with free flaps, I think you would see that patients have a similar type of positive view on the outcomes. Yeah.
Time for one last quick question.
Yeah, a quick question about radiotherapy. Do you find that the time that they receive the radiotherapy afterwards is delayed because of your reduction? And also, if they have complications, which are quite common after reduction type procedures, do you find that then you're actually delaying their radiotherapy that the oncologists are pushing for?
I would say that there's a lot less surgery with the reduction, or the large volume oncoplastic reconstruction, simply because it's a reduction pattern, and so the complication rates in the study is approximately 17%. the more surgery you do, obviously, the more risk you have for complications. And I would argue a mastectomy with a free flap reconstruction, you have chances of more complications or delayed.
There's less chance of them needing radiotherapy afterwards.
Oh, I see that. So at least in our institution at Tufts with radiotherapy, generally the most common complication that we have is the T-junction dehiscence. And generally that heals within 2 to 3 weeks. We haven't had a problem with that.
Thank you,
Generally,
Dr.
they heal well.
Chatterjee. I think we have to move on. Thank you.
So the next paper is going to be cost effectiveness and utility of routine pathologic evaluation of plastic surgery specimens. The presenter is going to be Dr. Mark Fisher and discussant Dr. Christine Road.
Thank you for the opportunity to present our work on the cost effectiveness and utility of routine pathologic evaluation of plastic surgery specimens. No disclosures. The cost of healthcare has been on everyone's minds and on the news lately, and for good reason. If we look at this graph showing the national health expenditure, in 1960, the United States was spending on average $146 per person per year for healthcare costs. And if we fast forward to 2014, that's ballooned to $9,523 on average per person per year. In terms of the total expenditures in 1960, it was $27.2 billion. And that skyrocketed to $31.3 billion in 2014. Even when adjusted for inflation, we're talking about a 1,400% increase in the cost of healthcare. So the question is, what can we as plastic surgeons do to decrease the cost of healthcare in the United States without compromising the care of our patients? And one area that we thought was fruitful for this is the utilization of pathology by plastic surgeons. Unfortunately, the decision of what specimens to send does not always lie with the plastic surgeons. Sometimes surgeons are faced with something like this, which is a set of guidelines from the institution. This comes from a community hospital, and I bring your attention to the lower half of this document that says that the below specimens must still be sent. This is actually a more liberal policy than was prior. If we look at number 4, it says that nasal bone and cartilage from rhinoplasty or septoplasty must be sent to pathology. Number 7 says that rib segments or other tissue that's removed just for surgical exposure, such as in a DEEP, must be sent to pathology. And then lastly, number 9 says that breast implants and tissue expanders must be sent to pathology. So looking at this, we decided to look at our own institution. So we reviewed all the pathology specimens that were sent at 2 tertiary care hospitals within our health system in 2015. We queried a database of pathology specimens for specimens that were labeled with the following: tissue expander, breast implant, fat, skin, pannus, capsule, hardware, rib, bone, cartilage, scar, and keloid. And then we narrowed the specimens down to plastic surgery cases only to keep it relevant to plastic surgeons. So what did we find? In 2015, we found 759 specimens that met our inclusion criteria. We then reviewed the pathology results for each of those specimens, and we found one clinically significant finding of seborrheic keratosis on a specimen of breast skin. What about the cost? So the cost for processing and interpretation of these 759 specimens was $430,000. So this cost is the amount that was billed to the insurance companies, and that is comprised of 2 separate bills. There's the bill for the professional interpretation, and that's what the pathologist bills for looking at the specimen, and then there's the bill for the specimen preparation. For the professional interpretation, we were able to obtain the amount that was actually collected compared to the amount that was billed. So you can see that $366,000 were billed, and collected was about $95,000. This is about a 26% collection rate. For the specimen preparation, we weren't able to obtain the amount that was actually collected, so we extrapolated from the professional interpretation using that 26%. We calculated that from the, $64,000 that was billed, the estimated collection was about $16,500. So in total, $430,000 were billed, and an estimated collection was about $112,000. So then we decided to extrapolate this data nationally. To do that, we used the AAPS statistics report from 2015 to look at how many cases were done, and we focused on tissue expanders and breast implants. So in 2015, there were 77,219 tissue expanders that were placed, and we're going with the assumption that they were subsequently removed and exchanged. There were also 17,892 breast implants that were removed, and this is just the reconstructive data. In the cosmetic surgery statistics, there were 24,661 breast implants that were removed. So in total, in 2015, there were 77,218 tissue expanders that were placed and subsequently removed, and 42,553 implants. So then we used our institution's data, and at our institution, 12% of all tissue expanders were sent to pathology, and 88% of all implants were sent to pathology. Using those numbers, we calculated that the cost for processing and interpretation of tissue expanders and implants in the United States in 1 year is $10.6 million. Again, that's only tissue expanders and implants, and in our data, that accounts for only 4% of the total cost of all the pathology specimens that we looked at. So what does this mean going forward? So our conclusion is that the infrequency of clinically significant pathology results does not support routine pathologic examination of plastic surgery specimens. And the emphasis here is on routine. So based on this data, we categorized specimens into 3 separate categories. The first category is specimens that may be excluded from pathologic examination. And this includes things like implants, tissue expanders, and pani from paniculectomies. The second category is the broadest category, and these are specimens that should be sent if there's clinical suspicion. And this includes things like skin, scar, cartilage, rib, keloid, and breast capsule. And the last category is specimens that should probably always be sent, and examples of these are things like skin and scar from a breast with a history of breast cancer. So we're hoping that based on this data, we can work with the governing bodies in plastic surgery to empower plastic surgeons to be able to make the decisions about what specimens are sent to pathology, and thus decrease the cost of healthcare in the United States without compromising patient care. Thank you.
Thank you, Dr. Fisher. I'm Christine Rohde from Columbia University Medical Center. I want to congratulate you on thinking about costs. It's certainly something that we talk about a lot now in this day and age. And I appreciated your thoughtful analysis. I do want to caution you on, in terms of your title and talking about cost effectiveness and utility, because the use of the term cost with utility I was expecting a little bit more of the analysis that we saw in the prior paper in talking about cost and utility. But I have several questions. One being, you do mention reasons that we send specimens besides just needing pathologic diagnosis. And I wonder if those are things that plastic surgeons really can't control, and what you would propose doing in terms of policy or in terms of getting buy-in from, for example, insurance companies or hospitals to help us to control this cost. For example, at my institution, we have to send off everything that we take out of patients. And I'm wondering if you have ideas on that, because you talk about empowering plastic surgeons, but we're not really the ones empowered when it comes to that. And as a side note, insurance companies often want to see that specimen documented so that we can bill for having done what we did. Secondly, you mentioned in your abstract that some specimens were labeled for gross identification only, and I'm wondering if there was a difference in billed charges if a pathologist was asked to only do that versus give a microscopic diagnosis. And then for your total calculated national charges, you mentioned earlier that you had billed charges versus collections. Was your final calculation based on an extrapolation from billed charges or collections? And then lastly, what could the potential impact on this be? Do you have an idea of the numbers we're talking about in terms of % of actual healthcare costs nationally?
Thank you for your questions. To tackle, I'll go in reverse order. I don't have a number in terms of the national costs for pathology. We were only able to use the data at our health system and then extrapolate that, which obviously is an estimation at best nationally. In terms of gross analysis, that's a great question. When it came to tissue expanders and implants, 93% of our specimens were sent for gross only. In total, about 12% of all the specimens we looked at were sent for gross only. In terms of the cost, we found that the average cost for sending something for gross only was $260, which turned out to be not very different than sending it for pathologic examination. So while I think plastic surgeons are cognizant of it and are sending things for gross only because they recognize that these things are not being sent for pathologic examination but are being sent for other reasons like you brought up, I don't think it actually makes a huge difference in the cost. In terms of empowerment, I agree with you, and I think that that's the problem, is that a lot of times specimens are being sent not because we want a diagnosis, but because we feel that the insurance company wants it or the hospital requires it. And that's where I think the governing bodies, the ASBS, the AAPS, et cetera, can come into play to empower plastic surgeons by proposing guidelines, by working with insurance companies, because the insurance companies wind up paying for the pathology. And your operative dictation should suffice as evidence that you did what you did. So I think it would fall to the governing bodies to help us by releasing guidelines, by saying these are things that probably don't need to be sent.
Bruce Mass from the University of Florida. I'll go, since I'm speaking. Just want to point out that for the last 10 years or so, I've thrown every expander and every pannus and every implant in the garbage can, in the red bag. And I've sent capsules, of course, particularly nowadays, and never had a bill sent back to us unpaid. So I think it's, at least in Florida, and our insurance climate, I think it's a fallacy to think that that we have to document what we take out in order to get paid. And I think that's sort of a thought process that's pervaded us for a long time. That's probably not true. So thank you for bringing this up to us. I just want to bring that point.
Thank you.
Yeah, my name's Gedge Rawson, and I work at Johns Hopkins Hospital, and you would think Hopkins, in most instances, is insanely conservative about everything. But we actually do have a policy that I didn't write, even though thank you for empowering me to write it, to have written it if it wasn't already in existence. But someone thought of this at Hopkins, and they made a list of a bunch of stuff that pathology doesn't want. All those things that you list up there on it. And so I haven't been sending those for about the last 6 years. And I just dictated my op note that I removed the tissue expander, and that seems fine. And I think they don't want it because they don't have anywhere to store it. And they have to store it for a certain number of years. I think they got tired of it. So, thanks. And if anyone wants a copy of that list, I could send it to you. And you could take it to your people and try to get a list like that made.
Thank you. And that's what we would hope to see, is that it'd be great if it could come from each institution, but I feel that there are some institutions that are going to be resistant to it, and that's where I think that the society and the association can come into play.
Yeah, Jim Zins from Cleveland. We do just what Bruce Mass said. The only addition I would say is that we photograph. We photograph it. So photographic documentation to me just would corroborate your op note, and certainly is as good evidence as anything from pathology.
So, Dr. Fisher, I had a question. Does the Joint Commission have a regulation regarding this paper?
So we did quite an extensive literature review, and while there are papers from different specialties, from general surgery, from ENT that have looked at this, there's no consensus guidelines in the United States that we can find about this. In the UK, there is a recommendation from the Royal College of Pathologists, which says that we leave it at the discretion of the surgeon.
Thank you.
I guess we'll take one last question.
Shouldn't the nurse's note from the operation contain that information? We received such and such, to augment the operative note?
I think that would be great, and but I think if the operative note is not enough, then what is? Because we're making the assumption that nobody's lying in their operative note, and that should really be enough to just say that you did it. Thank you.
Thank you, Dr. Fisher.
The next paper is entitled Single-Stage versus Two-Stage Arteriovenous Loop Microsurgical Reconstruction, an evidence-based review of the literature and analysis of institutional experience, delivered by Rebecca Nackstedt, and the discussant will be Steve Moran.
Thank you for the introduction. We have no disclosures. AV loops can be used in free flap reconstruction when the quality, length, or caliber of the donor or recipient vessels are not optimal. They can be used to navigate out of the zone of injury, which is important to avoid vessel fragility and spasms. They also can be used in cases of lower extremity reconstruction in cases of one vessel runoff. Vein grafts have been historically utilized for similar indications. However, vein grafts are associated with an increased rate of thrombosis. One study, specifically looking at head and neck reconstruction, found a much higher failure rate when vein grafts were utilized. These patients had a higher rate of irradiation, somewhat confounding this result. However, there still is anecdotal evidence that head and neck reconstruction and other types of free flaps have higher incidences of thrombosis with vein grafts. The benefits and drawbacks to a single-stage and two-stage AV loop approach are well known. Two notable differences: in a two-stage approach, you can break a long operative experience into two different ORs. However, there is then inflammation that must be circumnavigated at the second stage. Oswald performed a literature review and analyzed his institutional experience in 2007. He found a 7% failure rate in the single-stage approach and a 13% failure rate in the two-stage approach. Based on this, he concluded that you should use a single-stage approach whenever possible, as there was no obvious benefit to a two-stage approach. In this paper, however, there was minimal analysis of the loop or flap characteristics or minor complications. Thus, the aim of this study was to analyze the utilization of AV loops in free flap reconstruction, specifically focusing on complications and overall success rate and comparing a single and two-stage approach. A literature review yielded 35 papers, 24 using a single-stage approach, 8 using a two-stage, and 3 reporting on both. This yielded 260 single-stage AV loops and 98 two-stage. Since 2005, we have constructed 13 AV loops, 4 single-stage and 9 two-stage. The area of the body most commonly undergoing reconstruction was the scalp, followed by the lower extremity. The flap most commonly utilized was the latissimus. We had 4 complications, 1 in the single-stage approach and 3 in the two-stage approach. The single-stage complication was a clot evacuation in post-op day 3 and an ALT for a scalp defect. In the two-stage approach, 2 complications happened prior to the AV loop division, and an omental flap for scalp recon and an ALT for an abdominal wall defect, and one occurred after the AV loop division and free flap inset for a latissimus for a scalp reconstruction. Looking at the anatomical distribution of AV loops with our experience and the literature, the abdomen and trunk is commonly reconstructed using a single-stage approach, whereas the lower extremity is commonly reconstructed using a two-stage approach. The indications for loops: the single-stage and two-stage approaches are used with similar proportions for trauma, radiation complications, and neoplastic indications. Thus, combining the literature and the institutional analysis, we have 264 single-stage loops, 107 two-stage, and there was a similar complication rate when looking at minor complications. There was a much higher major complication rate with the two-stage approach. There was also a much higher failure rate when using a two-stage approach. So looking in the literature for surgical pearls, the inflow and outflow of the AV loop must be considered. If using a single-stage approach, the AV loop can be constructed prior to raising the free flap. This allows for testing the short-term patency of the loop prior to division. The topography of the region and position of the AV loop must be considered. If there's a joint that must be navigated around, or if the loop can potentially be kinked as the patient moves, flexes, or extends. The caliber and length of the loop must be considered. There was no obvious correlation in the literature between the length of the loop and thrombosis rate. Puceau's law dictates that flow will be directly proportional to radius to the 4th power and indirectly related to length. Thus, an AV loop that has a large radius and is short would provide the greatest inflow. Although this is ideal, this is not always anatomically and physiologically possible. When should the second stage be timed? The mean in the literature was 8.8 days with a range of 1 day to 2 months. There was no obvious correlation between timing to delay and thrombosis. Some recall the rule of sixes, which is used in AV fistula maturation. This requires a flow rate of 600 milliliters per minute. However, it's probably more pertinent to compare the flow in the AV loop to the norms of the region of the body undergoing reconstruction. Some propose that the AV loop should be allowed to arterialize prior to division. However, to our knowledge, there has been no histologic evidence if and when arterialization occurs in the short amount of time that an AV loop is typically allowed to mature for. It has been proposed that the ideal time to delay might be 24 to 48 hours, as this is long enough to test the patency of the loop, but it's short enough to prevent any inflammation from developing. So why is there an increased thrombosis in the two-stage approach? This is all purely theoretical, and it has not been definitively demonstrated in the literature. However, there certainly is a degree of selection bias, with complex patients and complex wounds undergoing a two-stage approach. Also, as previously shown, lower extremity recon was commonly done in a two-stage approach. For free flaps in general, there is a higher complication and failure rate in the lower extremity. Thus, it's not necessarily surprising that there was a higher thrombosis rate in the two-stage approach, with the high proportion of flaps being done in the lower extremity. From the AV loop standpoint, the AV loop in and of itself is an unnatural system. It is a high-flow system to a low-flow system without any resistance in between. So when you allow this unnatural system to exist in a two-stage approach, it can lead to turbulence, which can lead to thrombosis. Similarly, in a two-stage approach, the vein dilates. This can lead to size mismatch. This can be somewhat circumnavigated using simple interrupted sutures versus a coupler. However, this size difference still can once again lead to turbulence and thrombosis. In conclusion, there was a higher rate of major complications and failures in the two-stage approach. Despite analysis and literature review, there still is the unresolved question of ideal timing for the second stage. And flow dynamics, although ideal, have not yet been substantiated by clinical results. Thank you.
Steve Moran, Mayo Clinic. Becky, thank you for that very nice paper and trying to bring some science to a situation that most of us don't like to find ourselves in when we have to use vein grafts. I think the problem is, particularly with the last slide, when you say higher rate of complication, it implies a comparison between the two procedures. And I really think they're not comparable. I think the best thing that we can say, and I think your results corroborate those of Oswald in addition to the large Changgyang series, that there's really no benefit to doing a two-stage procedure. Maybe you could just comment on how appropriate you feel it is comparing these two groups that are done for different reasons and have a tremendous number of variables that aren't the same between a one-stage and a two-stage procedure.
Yeah, thank you, Dr. Moran. I think that's a very valid point. And although there is the higher complication rate in the two-stage approach, it is difficult to compare the single stage and the two-stage approach. And we don't really know why thrombosis occurs in the single stage or two-stage approach. But like I was suggesting in the last slide, I think that there's probably different dynamics going on that's causing a thrombosis in a single stage versus a two-stage approach. Just the flow dynamics of the loop and the high flow to low flow system. So I agree, it is very difficult to compare. And I think it's just good numbers to keep in mind when you're approaching each patient and trying to decide what is the best approach, a single stage versus a two-stage approach.
Based on your findings, what situation do you plan on using a two-stage approach in? Are there certain procedures that you can give us as a recommendation?
Mm-hmm. Sure, good question. So Cleveland Clinic is a tertiary referral center, so we get lots of very complex patients, and even with that, in the past 12 years, we've only done 13 AV loops, the majority of which were done in a two-stage approach. Some of these patients had failed prior free flaps and AV loops. So with these complex patients, I think where you want to test the short-term patency of the loop, it's beneficial to do it in a two-stage approach, test the patency of the loop prior to bringing in your free flap and potentially burning that bridge. I also think that in primary cases, if there's a large surgical removal required, if there's long operative hours expected, I think that in that case, it still might be safer for the patient to break the case up into two different operative experiences, less time under general anesthesia for 1 day. But it's still up to surgeon preferences, like I've shown, there's really not definitive indications as to when to use a single or two-stage approach.
We have one tweeted question. What do you think about the fact that you've arterialized the venous end of that vein graft? Can you comment on that from the standpoint of valves and how that may contribute to stiffness and perhaps thrombosis?
Sure. Yeah, good question. I think that that's another reason why it's been proposed to use the simple interrupted sutures versus a coupler, because just like you can't use a coupler for an artery because of the stiffness of the walls, you should use the simple interrupted sutures once the vein has undergone arterialization, potentially, and the walls are thicker, more stiff. It's also, on the other hand, beneficial, though, because as the vein dilates, you can then get increased blood flow out of your free flap once you inset the flap. So you just have to keep it in mind when doing the anastomosis to make sure that you're not setting yourself up for turbulence and thrombosis.
If there are no other questions, thank you, Dr. Nackstedt.
Thank you.
The final paper this session up for discussion is The Evolving Presence of Women in Academic Plastic Surgery, a Study of the Past 40 Years. Presenter Dr. Natalie Plana and discussant Dr. Linda Phillips.
All right. Thank you, everyone, for this opportunity. I'll begin by saying that female presence in medicine is increasing. Women are currently comprising 50% of U.S. medical school student bodies and have been doing so consistently for the past 10 years. Historically, women are underrepresented in surgical specialties. However, plastic surgery has typically veered towards higher female residency training than other surgical specialties. In 1990, almost 14% of plastic surgery residents were women, ranking plastic surgery 5th in not just surgical, but all medical specialties training women. This trend, however, is not paralleled in the demographics of academia in plastic surgery, as only 1 in every 10 AAPS and ASPS members are women. Significant gender disparities remain prevalent as women are less likely to follow a tenure track trajectory or hold leadership positions. And more recent reports have demonstrated that women are less likely to pursue research endeavors and consequently have, on average, a lower H index compared to their male counterparts. Yet, a broader study has recently demonstrated that women are simply less productive in the early parts of their careers, but can exceed male productivity in an average of 27 years. Some may attribute these findings to women's alternative or preferred lifestyle choices early in the career, but no driving cause has yet to be identified. Nevertheless, we believe that among women who do delve into plastic surgery, they have made substantial contributions to the academic literature. Therefore, the objective of our study was first to quantify the increase in plastic surgery trainees of women, and secondly, trace the academic footprint of female plastic surgeons over the past 40 years to determine trends in their academic pursuits. We reviewed ACGME data resource books to determine the percentage of female plastic surgery residents for every academic year available. We also created a roster of all academic female plastic surgeons active in the United States over the past 40 years. And we did so by identifying ACGME accredited plastic surgery programs and listing any female faculty currently active in their programs from their websites. Next, we contacted program directors to include any retired surgeons from their program, if applicable. And faculty biographies were reviewed to determine training years and, more specifically, completion of their training. A bibliometric search of each included surgeon was performed using the National Library of Medicine database. And through that, we gathered the total number of articles a woman published upon completion of her training, the journals featuring her work, and plastic surgery topics that they reported on. The 5-year impact factor of all journals featuring a woman's work was recorded. And publications were grouped into consecutive 10-year periods, as shown here from 1976 through 2016. We found that the percentage of female plastic surgery residents is slowly increasing, currently at 40%, which is nearly double where it was in 2007. And that's certainly a profound increase from 13.8 back in 1990. Our search identified 155 currently active female plastic surgeons and 80 retired surgeons. Together, they published 2,982 articles, of which 599 reported on basic science or laboratory work. They were featured in 479 peer-reviewed journals that had an average 5-year impact factor of 4.093. The number of publications authored by women in the last 4 decades exponentially increased with each decade, starting at 37 between 1976 and 1985, increasing to 218 between 1986 and 1995, reaching almost 500 between 1996 and 2005, and undoubtedly the majority of publications authored by women in plastic surgery were published in the last decade. Breaking down publications by topic, we noticed that in the first decade study, the majority of publications reported on hand surgery and peripheral nerve repair. In the late 1980s and early 1990s, the majority of plastic surgery topics that women were publishing on were started to increase and included breast surgery and educational or academic topics. Between 1996 and 2005, a more heterogeneous distribution of plastic surgery topics was observed, as women were publishing in nearly all areas of plastic surgery. Interestingly, microsurgery remained a low percentage of scholarly output. However, research in breast and craniofacial publications increased. And the distribution of plastic surgery areas became even more balanced in the last decade. Breast and craniofacial research equally yielded the greatest number of publications, and the proportions of microsurgery, aesthetic surgery, and education or academic topics all increased in the last decade. Despite this encouraging results, we acknowledge our study had several limitations, including a likely underrepresentation of female faculty who may have been active during the study period. This may in part be due to our reliance on the memory and cooperation of program directors regarding plastic surgeons' practice and training years. In addition, as we only reference the PubMed database, we acknowledge that our study and our search may not be comprehensive, as one database may not encompass an author's entire academic contributions. Nevertheless, in conclusion, female presence in plastic surgery is increasing both at the training level as well as in plastic surgery practice. Efforts to recruit more women by implementing a culture that is accepting of alternative lifestyle choices should be adopted in order to mentor women and provide them with the necessary tools to advance in the existing structures of academic plastic surgery. Despite common perceptions that some women are less inclined to delve into their research pursuits, our data demonstrates that women who do pursue academic research endeavors have made substantial contributions to literature that is exponentially increasing. And ultimately, we hope that studies such as this one can show that women should not be overlooked due to their slow acceleration in scholarly output, but on the contrary, our data unveil women's long-term potential as their presence continues to grow. They can lead full and productive careers in the right setting of mentorship and opportunities. Thank you.
I would
think you can leave now.
like to point out that it's not an equal playing field in height either. I'd like to thank Ms. Plana and the authors from NYU for this very nice study and congratulate you and thank you for sending me your PowerPoint ahead of time. I would like to ask if you compared the H factor and the paper numbers across all men grouped together and all women grouped together, because as you point out, the numbers of women have grown exponentially over the course of the last several decades. And so comparing us as an average would be actually comparing younger women on average to older men on average, as we know that there are fewer women in the upper echelons because there haven't been as many women as old as I am in the field to date. So I'd like to hear about that comparison. I would ask how you define the currently active female plastic surgeons, because if you're taking it from residency on, residency does tend to limit the amount of papers that many people can produce. I would like to caution everyone who is hearing this that it's not just alternative lifestyle, but it's a biologic imperative for women who choose to have their children, to have them earlier, because not only is there the decrease in fertility, but for women exposed to the operating room across all fields, there's an earlier decrease by approximately 3 years average. And finally, what do you have for suggestions to change the current status and improve the situation? Thank you.
All right. Thanks for those insightful comments, Dr. Phillips, and I'll try my best to answer each of them with the best of my ability. So I'll begin by saying that we purposefully did not compare women to men in academics because, as you nicely pointed out, it is an uneven playing field. So we decided to evaluate women's productivity over time and compare them just to each other, in a sense, and that's why we have seen this exponential increase, because women who have been active in academics in plastic surgery for the past 4 decades, yourself included, have made substantial contributions, and we feel that comparing those contributions to men's contributions would just be diluting it, and the numbers are just not equal. So we feel that it was more appropriate to compare women to each other and then just use the value of time for that comparison. As far as identifying currently active female surgeons, we identified any woman plastic surgeon who had an academic appointment at an ACGME accredited plastic surgery program. And we do realize that there are a couple of institutions, Memorial Sloan Kettering, for example, back in New York, that does not have a residency program, and so therefore there were a couple of female surgeons who were excluded from our search, and that's just another limitation of our study. And your third question, if you can remind me. Okay, so future suggestions is a difficult question to answer, and I think the task of recruiting more individuals into academia is an onerous one, and I will reference some numbers here. So I know that only 27% of plastic surgery residents enter academia upon completion of their residency. And even at that, there's a 40% attrition rate in the first 5 years of their practice. So I think that recruiting individuals into academic plastic surgery is very challenging, and that is not gender specific. That's for everyone as a whole. And so what I think our results here should highlight is the potential that women have. And those women who have designed their careers around research have been extremely productive and very prolific, as we've shown, and have set a new standard for the rising generation of plastic surgeons, specifically female plastic surgeons. So we should try to create a culture where women should not be overlooked because of a delay in productivity or a delay in their research pursuits because they decide to have choose a different trajectory in their career. And you nicely pointed out that it's not just alternative lifestyle choices. It is sort of a biological mandate, to sort of not put it so lightly. And so if we can, as a community, I'm only a rising medical student, so I can't call myself a member of the community just yet. But as someone who's aspiring to enter this community, I think that we can do a better job of being more understanding of women's desired choices in lifestyle, and specifically in key parts of their reproductive years. And I think that I'll sort of conclude by saying that the academic success of women in the past 4 decades has been substantial and may be the consequence of a cycle of individuals who have been open-minded and have been welcoming of women into what's often perceived as a male-driven specialty, but also because women who have been given these research opportunities have fully embraced them and taken advantage of those opportunities. So as long as the correct mentorship and the correct opportunity is given to a woman, then I think that that individual can contribute to science and plastic surgery with a lot of poise and be very prolific in doing so.
Any other questions? Thank you very much, Ms. Plano.
Thank you.